Welcome everybody to Empower Speaks Healthcare Talks. So as always, I will give you some background information about what Healthcare Talks is under the Empower Speaks umbrella. So as the name suggests, Empower Speaks is to empower, right? So how do you empower yourself? Through knowledge. And so whether you are a patient, whether you are a clinician, whether you're an individual in senior leadership, or you're in the entrepreneurial space, the idea is to have a variety of guests and kind of pick their brains and learn about their journey on a personal level, but also in the healthcare space, what are some of the issues, the challenges that they're tackling? So through those conversations, we are hoping to empower you. So today's guest is Dr. Mamdani. Now, before I hand it over to him, as always, I always do some background story on how I got my guest to be part of our session for today. So I'd actually reached out to Mama years ago, so I'm dating myself, when I had completed my Master's of Health Informatics at the University of Toronto. I had just graduated, and so I cold emailed him. I literally went on the St. Michael's Hospital page, I found his email address, and I'd reached out to him. And it's been years since then. He so graciously responded. I've reached out to him. I would find him at events. I would go, speak to him, and that's kind of how I got him here today. So the reason to share this story is sometimes, you just have to try cold reach out to individuals, and sometimes you get lucky and they do respond. So I always just want to share that, a little bit of insight there. And so, yeah, that being said, let's dive into our actual guest today. So Dr. Mamdani, I'm going to hand it over to him. And to get us started, I'm going to have him share a little bit about his journey. Right. So he started off as a pharmacist. Did he know that he was going to evolve into senior leadership positions? So just to give you a taste, he's in all over the place, but he has senior leadership roles at Unity Health Toronto, at the University of Toronto, Vector Institute, you name it. He's in the artificial intelligence and data analytics space. So I'm going to hand it over to him just to learn a little bit about his journey, and then we will go and pick his brain. So please, Dr. Mamdani, please share a little bit about your journey.
Sure. Thanks, Brian. It's a pleasure to be here. It's a wonderful platform you've created here. It's fantastic that people can come here to learn. And you're right. I mean, empowerment through knowledge. That's what we're all after, right? Yes, I'm a pharmacist by training. And I got to say, when I was in university, um, I, I was doing my schoolwork and training and with the books and stuff. And, you get a lot of theory, you get a lot of currently this is what we know. And then you get thrown on the floors. And I was in the doctor pharmacy program, which is a PharmD. It's more clinically oriented. So, typically people think of pharmacists as counting pills and dispensing drugs. And obviously it's a bit of that, but it's a lot more than that, especially on the clinical side where you're actually seeing patients and making clinical decisions. Really more focused on the drug side of things. Nonetheless, you kind of get to see firsthand healthcare in action. And I have to say it was a bit frustrating because when you go through and you talk to these patients who are in such dire need, these are some of the most vulnerable people. They've come to a place that actually where they're seeking care, and all you can do is go back and say, I know what the books say. This is supposed to be evidence-based because it's the era of evidence-based medicine. And I can't find a single study to help me make this decision. And I thought, medical science has progressed quite a bit. Evidence-based medicine has progressed quite a bit. So why am I struggling? And of course, you look to the mentors and you kind of get a sense of how they're treating patients. And you think, there's nothing out there in the literature that says this is what we should do, yet you just know because they have a ton of experience. But there's often a lot of times where, irrespective of how much experience you have, you say, I don't think this is the right thing to do. But you don't really know because it's basically an educated guess at that point where you're making medical decisions. And I've asked several of my mentors, like, how often do we make decisions without any evidence? And they said the vast majority of the time. So while we think we progressed significantly in medicine, and I think we have, don't get me wrong, there's been a lot of progress in medical science. I would say there's much more we don't know than what we do know. And I think it's that humility to understand that we don't know more than we know by a long shot, right? Because if you think about it, the human body is made of hundreds of trillions of cells, and each cell has over 100 trillion atoms. So all it takes is one misplace and you have disease, right? There's no way we can understand all of that anytime soon. But the other part of it is if you think about it, how do we make decisions? And it kind of dawned on me that it's all about data, right? If we think about when we're going to see that patient, we can see them. We can see that finger tremble and know there's some underlying neurological condition. We can lean in, we can actually smell that alcohol on their breath, knowing that there's some sort of a substance use issue there. We can listen to them and know that their speech is slurred. Maybe they've had a transient ischemic attack or a stroke. We have all these five senses, but all these things are going into our head. When we pull out the stethoscope and listen to the heart, it's not the heart rate that makes the diagnosis, it's the information that goes into our brain, along with their age, along with their frailty, along with all sorts of other parameters that helps us make decisions. And of course, you step back and you say, wow, that's a lot of information. And sure enough, people have tried to quantify it, saying that the average complex medical decision involves considering hundreds of parameters. And you think, wow, that's a lot to take in. How are you making those decisions with all those parameters? Are you even good at it? Well, there's a psychologist in the 90s named Miller who was able to show us that the average human can process 7 plus or minus 2 things at the same time. So yeah, of course we're going to struggle. And our decisions are not going to be perfect. And we're going to be incredibly inefficient. And this is where we see all sorts of issues, where when we look at common diagnoses such as asthma, studies have shown that 1 in 3 patients diagnosed with asthma roughly actually doesn't have asthma. Over half of patients diagnosed with schizophrenia actually don't have schizophrenia. So if we can't even get the diagnosis right, how are we going to get the treatment right? Of course, treatment is driven by prognosis in terms of what you think the patient's going to do. Study after study after study has shown how poor we are at prognosis. We're just not very good at it. And then, of course, you get to treatment, right? We're not great at that either in many cases. I used to work in a mood insomnia clinic when I was over at Sunnybrook with a brilliant psychiatrist. And I got to tell you, the vast majority of clinicians, the way we practice is when we treat something like depression, there's over, let's say 15, 20 drugs we can choose from. We usually pick the 3 that we're most comfortable with, have the most experience with, have read a little bit about, and we use those. And we try and see if it works. We call the patient back in 4 weeks. If it works, great. If it doesn't, we try something else. There's got to be a better way to do this. And studies have shown, there's a study by the U.S. Office of the Inspector General in the United States that about 1 in 4 patients, about 25% of patients will experience harm who are hospitalized. Medicare, Medicaid patients was a study in the United States. That's 1 in 4. 1 in 8 will experience harm so significant that it'll result in longer length of stay, requiring life-saving intervention, result in death, or result in permanent harm. And when they asked a bunch of experts how much of this could be prevented, they actually reviewed these cases and they said over 40% of these cases could have been prevented. Which industry really puts up with that level of inefficiency? Not many do, but we don't handle data well. So that's where I went and did a master's of arts in econometric theory of all things, economic statistics, because I wanted to understand the economic side of things. And then I went and did another master's in statistics and epidemiology, more quantitative again. And that's why I naturally gravitated towards how do we generate evidence? Was frustrated by observational epidemiology, clinical trials, because they all have incredible limitations, and thought, we got to have personalized medicine. And AI seemed like the thing that would be able to bring all that data together at that patient level, that one patient that you're seeing right now, tailor all that data to that individual and provide a good recommendation. That was the hope and dream of AI. And that's why I was pursuing it.
No, that's incredible. There's so much to unpack there. And I think that is so valid where you said that data is what drives those decisions, right? So as a clinician, for me to make an informed decision, if I'm missing even one piece of data, whether it's a blood test, you name it, X-ray, ultrasound, I cannot make an informed decision. And the other piece you said, even if we make it very simple, if you're doing a math problem, if you don't know what the problem is asking, you cannot solve it correctly. So same thing if we apply it to healthcare. Like you said, if we cannot diagnose what patient John Smith has, there's no way for us to accurately treat them. So I think that is so valid. And I love how you shared those specific examples as you kind of shared your journey of how you kind of evolved to here and what brought you into the artificial intelligence space. I'm actually going to dabble into one piece that I wanted to ask you. So last year when I had spoken to him, I'd shared with him that I'd written a paper with Kareem Khashoggi where we had determined that it was a lack of accessibility, not a lack of availability of data that was preventing us from training AI models, whether it's to predict certain conditions, what have you. And you had said something very interesting to me. And you said there are other players that need to be brought to the table to make AI a reality. So do you mind sharing a bit of that insight to with the audience as well of what you meant by that and how can we actually make it a reality from your insight and your experience?
hmm Yeah, a lot of people jump to data when they talk about AI, and I think that's definitely not the first thing that one should jump to. The AI program that we have at Unity, I think, is internationally leading, and it's based on a premise of start with the problem first. There's a famous quote from Einstein that I really like, and is kind of the basis of the center that or the program that we created. And the quote says, "If I had 1 hour to solve a problem, I'd spend 55 minutes understanding the problem and 5 minutes developing the solution." The data secondary. The problem statement is key. And how do you understand the problem if you're not working in that environment, if you're not dealing with the issues day in and day out? It's really hard to get a deep understanding of that problem. So I would start with people. I would start with who are the people who are really passionate, who are struggling every single day to make decisions when they don't have the necessary information or they can't find it or they can't process it or whatever the reason is, but they're struggling because they know intimately the issues. Then I would say, okay, well, now let's take a look at how AI or data could or may not be able to help. Maybe it's a process issue. Maybe it's something that requires more funding or has nothing to do with AI. But if it is a data issue, now let's talk about what data do we have? Let's not jump into access just yet. Do we have the data? Is it of sufficient quality? Is it of sufficient quantity to actually develop a solution? Then we get into accessing the data. So we have the problem. We know it's a big problem. We want to solve it. We have a really passionate end user who says, I'm willing to work with you and help you because I really understand the problem. I'm your partner. Wonderful. Yes, we have the data. It's of decent quality. We can get at it. But how do we access it? That's where we get into, all right, well, who gives you the authority to access it? Ultimately, it's the patient, right? Now, the challenge here is, are we going to, if an algorithm needs 20,000 patients worth of training data, are we going to go to every single patient, 20,000 of them, and say, can I have permission? Many of them have passed away. Many of them are so sick they can't really respond. Their caregivers aren't available. It's impractical. So hospitals tend to be custodians and physician offices and such. Healthcare providers tend to be custodians of that data. So they're known as HICS, Health Information Custodians. So they're able to store that data, leverage that data on behalf of. And of course, there's all sorts of power that patients still have. They can say, I don't want you using my data for anything other than my care. And that's totally legitimately their call. But I think a lot of patients would be okay with well-intentioned people using data to genuinely help them without identifying them, putting all the safeguards in place. So there's all sorts of policies and procedures around how we keep that data secure, private, and safe, and not harm patients, not breach security or privacy. But understanding what those rules are at the institution level becomes very important. So you get people involved, like lawyers, like privacy experts, like IT folks, like clinical champions, patients. You get all of them involved and say, this is what I'm trying to do. Are you okay with it? And how do I do it in a way that's going to preserve privacy, confidentiality, and make everyone happy? That's the process you have to build. And it's not an easy one because it's very easy to say no and keep doing what you're doing, then create a whole bunch of work for people in the off chance that maybe this is something that could actually help.
No, that's a lot there. No, I appreciate you kind of walking that us through that. And like you said, I think you have to reverse engineer, like figure out what the problem is, like you mentioned. And I think even earlier, that's what you said. You have to figure out what your problem statement is. Because me, even being on the vendor side, we can assume certain things, but we're not on the floor. So when they come back with certain problems, we can only predict so much, but there are things that will happen that we may not even anticipate. So I think that's so valid that you have to go to the front line and figure out where that problem is and what that problem is. It's not always a technological fix, like you said. It can be something simple as maybe we need to put a poster on the wall with X, Y, and Z,
Yeah,
and that's just that, right? It doesn't always have to be
absolutely.
technology, right? And so I think that's so valid. And then the other piece is you said, let's say it is an AI, a problem that can be solved with AI. And then once again, you have to reverse engineer. Do we have that data before we even determine is it accessible? And then the whole piece with patient, and I'm going to dabble into that in a little bit. But I wanted to ask you, do you think it is also legislation based? So last year I had ran a panel where we had a conversation about PHIPAA, good enough or time to
Mhm.
modernize. And in that, one of the examples I'd used is, for example, at a hospital, so sick kids, let's say they're trying to do some work in for a pediatric patient population, so they have access to their own data. Through their research, they can start working on certain things. But their neighbor in Ottawa, CHIO, they cannot share data with one another. It is based on the legislation, you can't share it. So just wanted to ask you your thoughts on that. Do you think there is also, in addition to all the pieces you listed, do you think also there is that legislation component that we have to be cognizant of?
I'm not so sure that's really true in terms of legislation because we're working under the current legislation framework and we actually have access to data to do these things, to develop these algorithms. I think it's education first and foremost. And yeah, it may be time to modernize a little bit, but I think the law doesn't say don't make best efforts to help people. I think it allows the ability to access data within certain parameters that protects people. So for us, it wasn't so much about, oh, we need to change the legislation as it was, let's understand what the legislation legitimately allows us to do and not do. Right now, our current legal counsel is fantastic, very knowledgeable, very progressive, very thoughtful. But previously, we needed to be educated in this space because it was all new to us. And this was prior to her coming on board. We didn't know too much about data privacy, AI, what it could, it couldn't do. So we actually had to go to an external legal firm who specialized in data, in analytics, and privacy, and get their opinion on, can we actually set up an AI program at our hospital? And while our institution was saying absolutely not, it's against the law, these external folks who are experts in the area said, absolutely you can. But here are the parameters around which you should work. So, and I think the argument becomes really easy if you start with the problem first. So, for example, one of our internists, Dr. Mulverma, is a brilliant internist at our hospital, said, I'd like to help people not die. It's hard to argue against that, right?
Yeah.
So if you take that statement and say, can we help people not die? And the thought is, AI can help me identify those patients who are going to be in trouble so I can act faster and be a better clinician. If you fast forward 4 years later after we've deployed the solution, tested, evaluated it, we published a paper in the Canadian Medical Association Journal, this AI solution that tells us who's going to die and it runs every hour has decreased unexpected mortality by 26%. It's actually helping save lives. Now imagine if you don't have the problem statement and you go to your IT folks, your privacy folks, your legal folks, your security folks and saying, hey, I'd like to play. Here's a something. They're going to say, of course not. But if you go in with a passionate clinician who says, look, I'm struggling here and I want to help people not die. I really want to save lives. It's really hard to argue against. Everyone gets around it and says, how can we make that happen? It becomes a little easier.
It's beautiful. No, I appreciate you sharing that. So, building off of that, does that mean the work that you're doing within Unity Health is because you're using the data of your patients, so it's kind of enclosed in that, and you can do it within your organizations? I know Unity Health is compressed of multiple hospitals, but are you only allowed to use it and exercise those tools that are built, AI tools built within that scope, or is there an option to scale? Or because of those limitations, we couldn't scale that, even though it worked for your physician and the other clinicians that are using it. Is there an opportunity to scale, or is it those limitations that don't allow us to?
No, I think it's again just comfort and knowledge. So everything we do is on-prem within our firewalls in the hospital. We are very conservative when it comes to security and such. That being said, we're heading into very intensive compute and AI algorithms that require what's called multimodal data that is going to increasingly basically reach capacity in terms of what we're able to do in-house at a hospital, where we will be using the cloud. And people may say, oh my God, you can't. Well, of course you can. People are doing it all over the world. In fact, we have hospitals in Canada now that are fully on the cloud. So their data reside on the cloud platform, whether it be AWS or Azure or whatever have you. And we're going to see more and more hospitals go towards that. as data requirements and storage and all that sort of stuff and compute needs increase over time, it's inevitable. Can it be done? Of course it can. It already has been done. It's just understanding how.
Okay. No, that's beautiful. And when you say understanding how is like what you mentioned earlier, it is that lack of knowledge. You need to bridge those gaps and ask those questions. Okay. And just kind of building off that, I know during you when you're in your response, you've shared an example, being mindful of confidentiality. Are there any other exciting use cases that you can share with us in addition to the one that you shared? Just so we have some insight of, how AI is being used to, like you said, reduce mortality, which is the end goal, right? So anything else that you may be able to share with our audience today in that regard?
Sure. We've deployed over 50 AI solutions at Unity, and so there's lots and lots of examples. We've evaluated many of them. I can give however many examples you like, but
Look, oh, wait, two?
maybe we'll pick a few. Yeah,
Okay, there
we'll
we go.
pick a few. All right. So maybe I'll pick something around efficiency. Um, there's a lot of healthcare provider burnout. Um, our clinicians are stretched; they're very stressed out. I can pick a nursing example, maybe, or a physician example. I don't know, which one would you prefer?
Good. Either way, because the first example you gave, that was physician based or that was nurse?
Yeah,
That
it
was
was more
physicians?
towards the physicians, although the nurses were involved, it was physician based. So we can go for a nurse one.
Nursing? Yeah.
All right. So our nurses came to us and said, here's our problem. Yeah, and you got to start with the problem. Um, they said, this does not sound glamorous at all. It sounds incredibly boring, but it is one of our top three stressors. And it really burns us out because it is so taxing. Scheduling nurses or assigning nurses to the different zones in the emergency department. We struggle with it every day because we have a lot of nurses. They need to be assigned to the different zones in the emergency department, whether it's acute, not acute, and so forth. And we have a lot of rules we have to adhere to. Some of them make a lot of sense. Others have been grandfathered in and it's the way it is. Other are union based. So we have to adhere to these rules and it's complicated. And we get all sorts of issues like, oh, I want to work with my friend this shift and all that sort of stuff. So they said, this is what we struggle with because right now we're doing it on paper and Excel. And we said, okay, why is this our problem? They said, because it's a huge time sink for us where our lead nurse, so our lead nurse, which is a senior nurse, spends 90 minutes a day on this task. 90 minutes a day, an hour and a half, where he or she could be providing patient care, could be doing more meaningful things. Our clerks spend 2 hours a day on this task. And we said, okay, well, how often do you violate the rules? And they said over 20% of the time. And sure enough, we looked, we observed, and it was about 21% of the time they were violating the rules. So we created, it's basically an individual level optimization algorithm with machine learning. And what it does is it basically tracks all of our nurses. So over the past few years, it's known who worked where, when, with whom. And it's all automated, so you don't have to do anything. The only thing you have to do is when a new nurse comes in, you just enter their name and there are a few parameters around them in terms of how much experience they have and their seniority levels and all that sort of stuff. But once you're in their system, it's good. It knows. So then you actually click a button and it'll do your assignments for the next 4 days, adhering to all the rules that you put in. And if somebody calls in sick, you can pull up the name and say, called in sick, click the button, it'll redo the assignments. So we've been using this for over 3 years now. And what we've been able to show is that the team lead went from 90 minutes a day to under 1 minute.
Wow.
Yeah. The clerks went from 2 hours a day to under 15 minutes. And the error rates, or how often they violated the rules, went from 21% to about 5%.
That is incredible.
Yeah, so a lot of time saved where they could be using it to do other important things, and error rates dropped because of it, right? Which I think is a good thing.
Just to follow up to that, when you said that in the
Yeah.
beginning, like the nurse that you just need to sign them up, and you said it would track like where they are. So was there a device on them to collect that data, or how?
No. So what happens is when you assign the nurse,
Mhm.
you actually assign it a different zone, a zone. So you tell it you're working in this zone. So you enter it into the system because, well, actually you don't enter the system. The system tells you which zone they're working in. And if there's any issues where the nurse argues and says, no, I don't want to work in the zone and I refuse to come in, or then you actually pull the name up and you say, no, need to reassign. And then it does an assignment again. So it knows where they've been working.
Okay. And the piece where you said about clerks where it reduced like errors. So because that they had that additional time, or not additional, the time that they could provide to care or what have you, that's where the errors were, because they weren't trying to struggle with their time of rushing to do this task of assigning and then all other. So that's where the errors decreased because they
Well,
could be present for.
well, it was a bit of that, but it was
Mhm.
also because the rules are so complicated, because you're so rushed to do these assignments and handle these things, you're it's human nature to say, "Oh, forget this. All right, fine. It's good enough." Right?
Right. Okay.
When actually over 20% average is pretty high. Um,
Yeah.
but the algorithm does things very quickly. What we take hours to do, it can do in mere seconds, right?
Yeah, and that
Uh,
that Yeah, no, I think that's so incredible because, like, even like with other conversations I've had, they have mentioned similar to the example you gave, that to use AI for automation of administrative tasks, right? Whether it's be scheduling, like you said, whether it's at a clinic, a patient's trying to schedule, or like you said, your human resources, your nurses, our physicians, you name it. So I think that's so beautiful in the value of that. And I think we see that administrative burden is quite huge. So the example you gave, where it's to do scheduling, but a lot of what we've seen over the pandemic or in general is patient documentation, right? Our physicians,
mhm,
our clinicians, that is a huge burden, right? And that's where a lot of burnout has come. And so that's where AI scribes have come in quite a bit. And I think in a comparison to other AI pieces, that is one piece that is being more readily accepted. And so I just wanted your thoughts on, AI scribes coming into the space. There's a lot of market for a lot of players in the space. So, one of the physicians I was talking to, he said that's, the low hanging fruit when it comes to AI. That's one piece. So just wanted to get your thoughts on that based on what work you have seen and the work you're in, and seeing that as well. Any thoughts on that?
Yeah, actually, and ironically, the first AI scribe in Canada was created in our place. So, yeah, there you go. It was a while back where family physician, a brilliant family physician named Dr. Noah Crampton, he was doing his residency at the time and said, it's insane that in today's day and age, I'm trying to have this meaningful conversation with my patient, and I have to say, "Oh, hold on, wait a minute." And I'm going to go type in my EMR. And now I'm distracted, but I'm going to come back to you. Oh, you just said something important. Let me type that back into my EMR. And there was this distraction. The notes weren't as good as they could be because, again, you're trying to focus on the patient. And when the patient leaves, you spend so much time fixing up your note because you didn't quite get everything. You have to remember bits and pieces. It just wasn't a good experience. And so that's where his idea was, can we not have the computer do it? Can we not have AI do it? Where it just listens to my conversation, transcribes everything. I push a button, it'll generate a medical note for me. Then I can review it and correct it if I need to. But basically, that bulk of work has been done for me. Seems like a very simple concept. And yeah, actually, it is a simple concept. It's technically a bit tough to do well because what happens is when you develop these algorithms, they can hallucinate or confabulate, they can make stuff up. And so you have to be very, very careful that the number of hallucinations is low and the extent of hallucinations is low. And that takes quite a bit of time and expertise to do. You can definitely create an AI scribe, no problem. But if it hallucinates over 80% of the time, you're in trouble. And if they're really bad hallucinations, like making up conditions that don't exist or going beyond the boundaries and advising on treatments that don't make any sense, that's a big issue, right?
How do you,
Um,
sorry, not to speak over you.
no,
How do you overcome that? Like, do you feed it more data to train it, or how do you do that?
Yeah, you increase training data, you set parameters around the algorithm, you basically tell it what the limits are, don't do X or don't do Y. You set thresholds in the algorithm. So there's many ways to actually minimize bias or confabulations, or I guess they're called hallucinations as well. So there are several tricks up the sleeve of the computer scientist to be able to do this, but it often boils down to as much training data as you possibly can get in a variety of situations and a lot of human review to say, I reviewed the conversation and man, the AI algorithm just messed up here. So you can mark it and say, this is where you've made mistakes and retrain and get the algorithm to be better and better.
No, that's amazing. Yeah, and even in the research I did, like you said, you have to constantly feed it data. And even
Yes.
where I work at right now, we're in the mental health space. So we're a telehealth and patient portal, and they also built an AI scribe, which is integrated into the electronic health records they're using.
Mhm.
But like you said, like at the end of the day, the physicians, like as they were doing testing, they would, or any of the clinicians, they would have to review it, and then based on their discretion, they would put what they want in the template in the EMR or EHR. But like you said, they would take that feedback, like, hey, this was really good. We got or this was an issue or what have you. At the end of the day, they said that the notes were better than theirs. But I think, like you said, you have to constantly test and feed it. And so I think it's so incredible. Like you said, it's simple things, but like I think to the point is determining the problem. There was a physician, like you said, Dr. Noah Crampton, that he said that this was something that I had a pain point with and in trying to solve it
Mhm.
and then reverse engineer it. So yeah, so I
Absolutely.
appreciate yeah, sorry, go ahead.
No, absolutely. I mean, I think it all starts with the problem. And you get brilliant technicians and computer scientists to come in and actually try and develop solutions with the physician or clinician or end user to develop something that actually works. And this is where a lot of people have gotten into the space of AI scribes. I think the challenge we had is that in the Canadian healthcare system, innovation is not very well funded. So you try and cobble things together and you move at a much slower pace than you normally would in other countries. Um, so by the time we actually were able to get to a place where Noah was happy, said, "Hey, we should have a startup around this." We said, "Absolutely, you should." Years that went by, and there were many other competitors in the space. Um, some good, some not so great. Um, but I think the key trick is if clinicians are using it, they're not finding a lot of challenges with using it. So hallucination rates are low, and they're getting a lot of benefit. Then it's working.
Yeah. No, that's so true. And that's incredible. I want to kind of change segues into the patient perspective.
Mhm.
If possible, I know you said you had multiple examples, and there are so many things I want to ask, but I think it's beautiful to hear these stories so we're aware of what is happening. If possible, and like I said, always mindful of confidentiality. Is there an example? Like I know you said you guys have done 50 projects in the AI space. Is there any one that you could share potentially that's related to patient outcomes? Even the example you gave down the line, it still improves quality of care, all of that. But are there any examples patient specific that maybe you could share with us?
Sure, sure. There's lots of patient examples. We like to do clinical AI algorithms. One is around, well, I'll give you a case example. So maybe I'll tell you a story about this. This is an actual patient that came to St. Michael's Hospital actually last year, no, the year before. And she was at home and she was really having an incredibly bad headache. And it was a headache that she'd never experienced before. And she said, "This is highly unusual. I'm going to go to a community hospital." So she did. The emergency medicine physician told her to go home, and so she did. The pain started getting worse, numbness down the arms, stiffness in the neck. Went to a second community hospital, and the physician ordered a head CT. Head CT came back, and the physician said, "I don't know, probably a bad headache. Why don't you go home?" So she did. She started blacking out. So she was rushed to St. Mike's, and as soon as she came into St. Mike's, she was rushed into the operating room. The neurosurgeon said there were 3 infarcts in her brain, so 3 dead spots, and there was a 90% plus chance that she would die in the operating room. But luckily, she survived. But she was left in a persistent vegetative state, and she has 5 kids. The family was devastated. She was devastated. It's just an unfortunate situation, right? And if you look at the literature out there, 1 in 10 to 1 in 20 brain bleeds are missed. 1 in 10 to 1 in 20 brain bleeds are simply missed in the emergency department. So if you come to St. Mike's, you'll see this thing in the clinical area in the clinician area in the emergency department where it looks like you're at an airport. Basically, it's a monitor that scrolls up all of our patients in the emergency department. It lists the emergency medicine physician who's looking after them. It lists the medical imaging test they ordered. It lists the radiologist who's looking after the test. And it lists the current status of the test. So it kind of scrolls up all these names. And every now and then you'll see this little blue symbol that says ICH. We have a parent algorithm called TBI. And basically what that means is this patient has a brain bleed or has traumatic brain injury that needs an operation right away. Don't wait. That's our AI. So our AI screens every single head CT that's ordered in the emergency department, and in less than 2 minutes, it will tell you if the patient needs an operation right away. So it pages the neurosurgical team. So the neurosurgical team is on it. The same monitors on the radiology suite, so the radiologists are aware as well. This should be at every hospital in the province, especially in hospitals that don't have neurosurgical services or neuroradiological services. That's really where you see these poor patients suffering who are going to have these bleeds without treatment, and you lose brain function every minute. So luckily, we're able to capture them. Now, if we look at the performance, our traumatic brain injury algorithm was compared to 5 board-certified neurosurgeons, and it performs just as well. In fact, it slightly outperformed them. It missed fewer cases. A hospital in the Sioux, for example, or up north may not have a neurosurgeon to look at these images, but this algorithm performs just as well, if not a little bit better.
Okay, that's incredible. So just to reflect back, so the way it works, so to train the model, you would have used past patients' data that we had missed their brain bleed, and you use that to feed and train the AI model. And because its accuracy is even greater than human, well, we'll put it as that. So, like you said, rural areas where we can use it. So in those areas where they may not have neurosurgeons or as accessible, the fact that it can be caught, that patient can be flown in, or is that what you mean where we can, okay, so now because we're acting faster, other resources can be pulled to provide them with the care, even if that area doesn't have the resources, the tools allow them to predict or diagnose, and then they can start planning for, okay, we need to fly them out to X, Y, and Z, or however, even if they do
Yeah,
have the resources.
absolutely. Well, if we look at the statistics, we've looked at some of our own data, and the way we've trained the algorithm first and foremost is our neurosurgical team actually came up and said, this is a big need for us. Traumatic brain injury is a massive need. So we actually have a brilliant neurosurgeon, Dr. Chris Wichu, who is absolutely fantastic and generally cares about his patients, and said, look, this is a huge pain point for us. It provides better patient care, but it also makes our lives easier because as neurosurgeons, he was telling us, we get over about 2 to 4,000 consults every year at St. Michael's Hospital alone. So he's getting up at 3 in the morning looking at scans. He's having to actually interrupt his operating room time while he's operating on a patient to go look at an urgent scan. And what he told us was about 90% of these referrals that are urgent actually aren't necessary. And when we look at transfers, 40% of them are inappropriate. So clearly there's a need with an incredibly inefficient system to be able to do this better. And that's where I think hospitals like ours, where we have neurosurgeons, we have neuroradiological services, yeah, we see benefit with the algorithm, but not nearly as much as you're going to see as a community hospital in rural Ontario that has barely any of these specialty services.
No, I think that's incredible. And I appreciate you kind of breaking it down because even in my own mind, I was trying to connect the dots. Like you said, that neurosurgeon, instead of them being in the operating room, they're being pulled away to look at, scans or what have you, which is valid. But like you're saying now, the AI tool can do that, certain pieces that can be automated. And so that way, and also in terms of resources, right? That's another piece when it comes to the healthcare system where our resource allocation sometimes is not used as well, right? Even for tests, like I'll have a blood test and my family physician, but then if I'm brought into the ER, they may not have access to it. They may not, and then they'll run it again. That's a waste of time. That's a waste of money, right? So I think to your point where now that neurosurgeon can be very focused on providing that patient care, performing his surgeries, what have you. And so that the cases that don't need his attention are not gathering that attention, those patients can be guided appropriately because that also can overwhelm them too, that, oh my God, I'm being referred to here. So there's so many pieces. So I know I'm kind of getting like overexcited, but I was trying to
Yeah.
like connect the dots as you were saying, there's so many pieces around that. And so kind of honing in on the patient side, I know earlier when we had talked about that data, you had said that, yeah, we have the HICs, but at the end of the day, the patient, it's their data. And so I wanted to ask you your thoughts twofold. One fold about bridging the gap of knowledge to let patients know that, their data being used for X, Y, and Z and gathering their consent, but also on the flip side where the patient, like you said, it's our data. So us being the carrier, will that be a reality? Because right now we talk about interoperability and there are so many barriers, but the patient, whether I'm being seen in Ontario or I go visit Alberta and something happens, I'm pulled in the air. If my data is traveling with me, the fact that I'm in a different province won't impact my care because it's coming with me. So just wanted to get your thoughts on the gap in terms of education for patients when it comes to their data and then actually getting access to your data. Any thoughts on that?
Yeah, we have to gravitate towards that, but the realist in me says it's going to take a lot of time. We are way too fragmented. Our technology is not coordinated whatsoever. There are many, many, many challenges. Now, when you have a province like Alberta, for example, where the entire province has said, we are all going to one electronic medical record vendor, right? Nova Scotia is doing the same thing. Quebec is supposed to gravitate towards that as well. It puts pressure on other provinces as well, but at least you have a common platform now where you can share data much more easily. Now the issue becomes not as much technology, there's still some technological issues, but more about privacy, sharing, who we allow, who we don't allow. Governance is basically it. And I think we need strong leadership who says, not everyone's going to be happy, but here's the decisions we are going to make in the best interest of society. Some people will be upset, but the majority should be okay. And in fact, this will benefit society overall. We have to have the courage to do that. I'm not sure that many of us have that courage. So it's going to be a combination not only of technology, but I would say even more importantly of courage.
Courage, and to build off that courage in the sense of, like you said, the way other provinces have tried to kind of unify, where, like you said, they're using one single electronic health record. So it'll help. It's basically an enabler to allow us to achieve this goal. So what you're referring to is taking the courage to also follow in suite in terms of that, and then keep taking additional steps. Or what did you
Yeah.
mean by that?
Well,
Yeah.
if you look at some other countries, like Estonia, for example,
Okay.
Estonia of all places, right? You have everything in your phone on your phone. There's an app, and basically the health IT infrastructure is all coordinated across the entire country. So you can go from one end of the country to the other. You'll have all your data in all the places you visited, your hospitals especially. So if there was a head CT done at one hospital, but the next time you needed to go to another hospital and you had different lab tests done, all there, right? And you are the carrier of that data. You're able to look at whatever you like. That's really how it should be. Now we have in hospitals right now, there's a popular thing called MyChart, for example, on the Epic platform. Yeah, that gives patients access to data. It doesn't have all the data. It has enough that you kind of have a sense of what's going on. The other challenge is it's often not interpretable. A lot of people read it and they don't understand half of it. So I see a future where if we have courage,
Yeah.
we would be able to say it's not a choice anymore. These are the standards from an informatics perspective that everybody has to adhere to. So we're not going to dangle carrots. No, there's a stick. You have to do this. There will be standards. Everyone will adhere to them. That we will have common platforms. Patients will have access to all of their data, but there will also be AI types of technologies that will be able to take all of that data and explain to that individual patient in Mandarin at a grade 11 level what's wrong with them, what medications they're on, when their next follow-up appointment is. It's on their terms. It's on the patient's terms in the way they understand it and the way they need the information. That's the promise of AI, powered by technology that enables it.
No, and I think that's so beautiful and so important, because even the patient side. So where I work now, they develop a feature called View Client Data, so a patient can have access to their medications, diagnoses, lab results, all of that. So as a vendor, we cannot withhold patient data, but our organizations can ask us to not share certain data points. Some of them have concerns about the diagnoses or medication. So like you said, there's that gap there of what this means, what that data means, so that but the patient still should have access to it, right? So we can recommend as a vendor, but we cannot force them. So I think that that leads to your point where everyone kind of abides by that. The second piece is, even for myself, I think, so I had a recent injury, and so I went to get my x-ray and ultrasound. But because I am in the healthcare space, I have health literacy. When I finished my appointment, I asked them, can I have access to my x-ray and ultrasound? So they printed out a page so that I can go look into my portal, what have you. What if I didn't have that health literacy? I would not have known to ask for that. And
That's right.
because I'm in that space, I know to keep that. So in case something else happens, I can be like, okay, this x-ray was, but that goes to that piece, right? Like everyone should have access to that. It's not just because I'm aware of it that I should ask for it. It should readily be given to me. So just wanted to get your thoughts on that, like the knowledge piece of health literacy, right? And their social determinants of health. So much goes into it. And not even that, like my sister, she's a lawyer. She's like, I would not have known to ask, but because of me, she knows to ask that. So just wanted to get your thoughts on that patient side of it.
You shouldn't have to ask that.
Exactly. Yep.
This should be, this should be socialized that this is our right.
Yeah.
We have a right to our own health information. And when people say, don't disclose this information, that's not your decision to make. It is the patient's data, it is the patient's information. So I think patient empowerment is incredibly important. We need more advocacy there. But I think it again takes the courage of a system to say we're actually genuinely going to listen and enable it. So, you have Pocket Health and vendors like that, and there are more and more of these folks who are actually trying to assimilate all that data for the patients. Why aren't we doing this as a healthcare system? Why does it take private sector to drive this? It shouldn't. Unfortunately, it does. And I mean, more power to the private sectors who are pushing the agenda. But this should be a societal norm, not a want to have, and maybe I can have, but it's just there because I don't even have to think about it.
No, and I agree. Like when I went through that, because it's very recent, I was like, oh no, like I was able to, but you're right. Everyone should. And I truly believe that. And just because now we're talking on the patient side, on the clinician side, when you are rolling out these artificial intelligence tools, do you get any pushback? Are there any gaps of knowledge that you need to bridge, even with the clinicians to get their buy-in to use those tools so that they can, help you
Mhm.
test it and have that outcome of improving patient care and all of that. Any issues that you've experienced there, and how have you addressed those gaps?
Yeah, there's always going to be end user issues. Some are going to be much easier to handle than others, but our model is built so we minimize those acceptance and adoption issues. And the reason why it hasn't typically been a big issue for us is because the end users are there from the beginning. It's their idea. It's their struggle that they deal with every day. They co-create the solution with us. And it's not just an individual, it's entire teams that come and work with us. So because they're spending so much time and energy, they're getting exactly what they need. Otherwise, we don't deploy the algorithm. Then deployment is not an issue because they
Right.
champion it. They're the end users, right? So it becomes very easy. Now, that being said, um, are there some challenges? Yeah, one I can highlight actually. So the ChartWatch example, this early warning system that predicts if somebody's going to die or go to the ICU and alerts our medical team. Um, we had, I think it was 17 internists or so.
Okay.
And many of the internists were saying, oh, so this is a prognostication algorithm. So it basically predicts who's going to be in trouble. And some clinicians said, oh, wow, yeah, no, we really need help with that. But there are a few clinicians who said, I don't need any help with that. I'm amazing at it. I'm so good. Why do I need an AI to do it for me? I'm not going to use it. So, of course, we went to the floors and we said, all right, let's see who's right. And we needed to do that to actually convince people and have buy in. But we spent months doing this. And we said to our clinicians, we're on the floor right now. This is not a hypothetical case. This is a patient you're following. So you know this patient. You just finished rounding on this patient. Tell me if they're going to die or go to the ICU. Give me your prediction. I mean, you're saying you're very good at it.
Right.
So we collected over 3,000 clinician predictions. We were able to show that when a physician says this patient is going to die or go to the ICU, they're right less than a third of the time. Right.
Goodness. Yeah.
Yeah. So when they see the data and they say, okay, maybe I'm not so good at this. Maybe I could use some help. When we're able to show that among the patients who die, you're able to identify less than a third of them, but our AI solution can more than double that number. Well, now it becomes a bit more interesting to clinicians, right? Saying, okay, this can help me do better. And so sometimes you need a bit of that data to
Yeah.
say, let's be realistic about how good we really are at things. Let's document it and let's see how we could do better. Because we're all in it for the same purpose. We're not here to embarrass anyone.
Yeah.
We're here to help our patients.
Exactly. No, and I appreciate you sharing that. I think that that's so critical. I think the piece where you said, like, I always say this, we're all patients. It doesn't matter your title, doesn't matter your profession. Either yesterday, in the future, a loved one, we're all patients. So at the end of the day, always don't think of it as third party to you. We're all patients. So
Mm.
I think that's beautiful the way you kind of phrase that. And I think, like you said, data points, even for us, when we're presenting to senior leadership, they always say the numbers. So, like you said, same in your case.
Mhm.
You collected that data, like, here you go. And like you said, it's not to humiliate or anything of that sort. It's just to show, like, okay,
Mhm.
you have X, like you said, even the neurosurgeon, they're there to, do the surgeries, what have you. And then there can be tools to augment, sorry, certain pieces, like you said, so predicting X, Y, and Z. So you can go ahead and provide that care and use your expertise in that space. So I think that's incredible. And the piece where you said that stakeholder engagement, they were there every step of the way, and not just certain team members, the whole team. I think that is so critical because right now, like I'll say, completely transparent, on the vendor space, we'll have certain team members, but it'll be just key stakeholders or key team members that will, give their feedback or what have you. But the fact that you could get a whole team, that way you can eliminate missing certain points. So I think that's so
Yeah.
incredible that you had
Now,
the
now clarify, like the reality is the entire team can't be there the whole time. But when we actually deploy, there is a massive engagement of the entire team. So we have literally had deployments that have involved 50, 60 people with full change management, education, all that sort of stuff in there. And we've actually, when we did the ChartWatch thing, for example, right at the idea conception space, we had the entire team there saying, look, challenge us. Is this a good idea? Are you guys bought in? So yeah, teams have to be engaged for sure.
Yeah, no, and I appreciate you kind of sharing that. Like you said, it's not being realistic, right? Like, so not all the
Yeah.
whole team all the time, but certain components of them or certain portions. But I think that's so beautiful. Today's conversation has been so incredible. I just want to leave off with
Thank
one
you.
piece. Either any closing remarks or what are you most excited about in the artificial intelligence space or anything you want to share with the audience that maybe we didn't get to tackle as we wrap up for today?
I think artificial intelligence has a lot of potential to help us because it's able to go through information, data, which is the foundation of healthcare and management in terms of how we understand health and how we improve health. We struggle with it as humans. And if we have technologies that can actually improve our performance, help us genuinely to drive the agenda of improving patient care, we should be embracing it, not being afraid of it. But it starts with literacy. Let's learn. Let's learn as much as we possibly can. And let's also learn when not to use AI because it's not going to solve all of our problems. In fact, it will burn a lot of resource, energy, and time on something that could be solved with a sign or sometimes a hug.
Yep.
So I would really encourage people to learn more about AI, understand the incredible power that it possesses, but also understand the limitations and where maybe it's not so appropriate. But keeping in mind the main purpose that you're driving towards in healthcare is to improve patient care.
So that's beautiful. So that kind of just wraps up today's session. And like you said, patient care, it's the idea is to empower patient empowerment, clinician empowerment, you name it. So thank you so much for taking the time to speak with
Thank
us
you.
today and share all your knowledge and insight.
Thank you for having me, Frank.